So our group project was fall risk prevention. It will be presented by Lori Jang, Kiana Fenty, Kelly Graves, Sarah Mann, and Stephen Foth. Next slide, please. Issue identification. Falls are one of the top 20 costly medical conditions and health concerns worldwide. A clinical fall risk assessment performed found that 28 to 45% aged 65 and older fall on a yearly basis. 80 to 40% of these falls bring adults to the ER, and they cause 80% of hospital admissions. Injuries from falls are found to be common in older adults and usually cause hip fractures and traumatic brain injuries. Next slide. Governing regulations, the Joint Commission has created a national patient safety goal aimed at fall prevention. The Joint Commission states that the organization should evaluate the patient's or residents' risk for falls and take action to reduce the risk of falling as well as the risk of injury should a fall occur. Next slide. Quality variance. Falls are proven to be a very costly event. In 2012, falls that caused fatalities cost $616 million and rose to $30 billion in 2015. In 2012, falls that were non-fatal cost $637 million, and in 2015, $31 billion. According to the Joint Commission, the average cost for a fall is about $14,000. Next slide.
So as we take a look at what the root cause of the increase in expenditures among these hospital facilities, we have to take a look at the intrinsic and the extrinsic factors. Intrinsic including when we look at the individual as their personality, their cognition and mood, and whereas areas of environmental influences, such as the extrinsic factors, focus on the things that are outside the personal, whether it be the weather, physical environment, or the particular rules or regulations that they have within these facilities. So when we take a look at things that are affecting these patients, we take a look at the medications such as the diuretics, the antihypertensives, a lot of the antipsychotics, antihistamines, narcotics, hypnotics, these things that have very adverse effects that affect patient mentation, whether or not they're able to get up and walk, affects their BMAT level, and then also affects how they get around from place to place. Next slide, please. We take a look at what the biggest causes were. The highest risk for falling has a lot to do with just polypharmacy, vision and hearing impairments that go along with the patient, memory loss or confusion, and a lot of pain. These are some of the highest things that affect patients' risk for falling, as well as the staffing to patient ratio. There has been a staffing shortage along with associated with a lot of fall risk with patients. It obviously increases the fall numbers, and then the need for putting more staff to monitor patients is just very important to have and be integrated into an actual mode in which we carry out and through the facility. Next slide, please. We took a look at the assisted living facility in San Diego, where the fall risk is obviously elderly patients. We take a look at a lot of the RNs, LVNs, CNAs jobs, what that allows us to do. We take a look at the other healthcare workers and how that affects what is done with the patients as well. And then how we're going to be presenting future patients following guidelines that we can implement in these other facilities. Next slide, please. So a solution would obviously be paying more attention to the bed and chair alarms. I know myself, sometimes we're very callous to the fact that a lot of call lights go off. We're very numbed as nurses to hear a lot of things go off, and our immediate reaction isn't to go right away. This is something that needs to be changed as far as a culture-wise to improve these numbers and reduce fall risks. A lot of the similar fall risk assessment scores, such as like the bed rail transfer bar safety assessment, the fall risk evaluations, psychoactive medication evaluations, and change in condition assessments are all very important to implement and stay on top of as far as fall risk assessment goes. And the goal pretty much is to reduce the number of falls. And obviously that's hopefully going to decrease the costs associated with these falls. Next slide, please.
Okay, now I'll be talking about the different forms involved with the fall risk before and after the fall has happened. The first form I will be discussing is the bed rail transfer bar safety assessment. It asks important questions such as if the patient is a non-ambulatory, has difficulty with the balance or poor trunk control, and other important considerations are if the patient is on any medication that requires safety precautions and has a history of falls, and if the patient is a visually challenged. Next, please. The next form is a fall risk evaluation, which is similar to the fall risk assessment score. And this score takes account of the number of the falls in the last 12 months. Slow walking speed, changing gait, loss of balance, poor sight, weak hand grip, and age. Like the fall risk assessment score, the fall risk evaluation takes account of history of falls, vision status, and gait, balance, and ambulance. There are factors that are not considered in the fall risk assessment score, such as mental status, elimination status, systolic blood pressure, medications, and a predisposing disease. Next slide, please. The next form is the psychoactive medication evaluation. Psychoactive medication are a well-documented risk factor for fall injuries with adverse effect of hypotension, sedation, and gait abnormalities. In this document, it notes the mental status and any behavior problems of the patient. Next slide, please. This next form is change in condition, which is usually documented after a fall has occurred. In total, there are 17 pages because there are 30 other possible changes other than just falls. The first couple of pages notes the date, time of the day, change in medications, and most recent vital signs. Next slide, please. All right, so these couple of pages address pain level and evaluate a cognitively impaired patient, which is also a huge risk factor. In this section, it look at breathing, negative vocalization, facial expression, body language, and pain. There are many sections dedicated to pain, specifically in the abdomen, back, headache, and overall musculoskeletal pain. All 4 documents discussed are crucial in combating fall prevention and addressing falls when it does happen. Next slide, please.
So I'll talk about solution implementation. The first step is when the resident arrives at the assisted living facility, we should complete all the fall assessment evaluation forms that Lori just spoke about, the bed rail transfer bar safety assessment, the psychoactive medication assessment, and the initial fall risk evaluation. It's important to individualize a plan of care when assessing fall risks for these patients to determine what kind of precautions or technology they'll need in place. Secondly, we need availability of working fall prevention technology like bed alarms, call lights. RNs, CNAs, LVNs, whoever's on the floor should immediately turn in any malfunctioning technology to maintenance as soon as possible, just to make sure that we have all working devices on the floor. Stakeholder involvement is number 3, and there should be adequate daily staffing. Understaffing is a risk for more falls. There's not as much eyes on the floor, ears on the floor. That can be handled by allowing self-scheduling employees have their preferred schedules, so maybe less call outs, hourly rounding by each of CNAs, RNs, and LVNs, just to make sure that patients aren't getting out of bed for little things, and get inputs from everyone on the floor just to find out what's working and what's not working. So the timeline that we created, by January 1st, we want to have self-scheduling and implementation of a no pass zone happening. So self-scheduling can help with staff not calling out as much. The no pass zone, whenever somebody sees a call light, they can't walk by it. They just have to check in. Sometimes it's like, oh, can you just pick this up for me? And if it's more than that, you let the patient know that, or the resident know that someone's on their way to come and help. By January 15th, there should be weekly stakeholder safety meetings and continuing every Friday just to get input from all the stakeholders and see what can be improved upon. By February 1st, we want to have fall risk assessments on file for every patient. Incoming patients as well as current patients must have every fall risk assessment on file. And June 30th and December 30th would be the 6 and 12-month analysis, just to find out if what we're doing is working. Sarah, you're on mute.
Hello, I will be discussing the analysis portion. After the changes have been made, success of the program will be determined by analysis of the following measures. We'll analyze the number of falls. We'll also analyze, we want to know the severity of the injury and the type of injury. Was it a fatal injury, head trauma, fracture, etc.? Is this a readmission? Is this a repeat fall after the previous fall? Or was there another cause or probable cause of the fall, such as the medications, previous injuries, altered mental status? We also want to know, was the resident receiving assistance at the time of the fall or no assistance? Was it witnessed or unwitnessed? And we'll also be analyzing the fall risk assessment scores. Was the resident a fall risk? How was the staff on the unit that day or on the floor that day? Did we have a full staff, a short staff? Things like that will need to be looked at as well. And then the preventive measures that were in place, such as bed alarms, bed rails, call lights, no slip shoes and socks, having walkers and canes like that available. Next slide, please. Okay, so after the analysis, it's important that we share the information with the interdisciplinary team. We want to share it with the team because that way we can determine what and if measures reduced falls. We also want to know what and if measures had no effect on falls. Do bed alarms work? Maybe we get information like that. And then is it possible that we've done something that may have increased the falls, the chances for falls? That will be reviewed as well. So after the analysis, we'll share the information with the team. We'll review again the conclusion of the analysis. And then importantly, we want to reinforce those measures that reduced falls, and we need to discard ineffective measures. And we also want to make this program cost effective. So after determining the total cost of the injuries versus the cost of the program, that can also be worked on as well. But the number one priority is patient safety and then reducing cost as well. Thank you. Next slide, please. Any questions?
I think I have one more